Hey Alex, I got the results from the biopsy and cytology we did last week, and I want to ask you a few questions about your background and kind of follow up with some other questions. So, how often do you drink and smoke tobacco?
Well, I drink about 5 drinks a day. It's small, and usually about 2 packs of cigarettes a day, because it gets me through the day.
So, tell me, does your family have any history of cancer or anything like that?
My family history of cancer? No, not that I know of. I don't really talk to my family too much, so I don't know. But I do have this blood condition called Falconi anemia. Do you think that's gonna be a problem?
Okay. Well, Alex, after running the biopsy and all that on the leukoplakia and lesions that you have, we find that they're actually cancerous, and I'm sorry to inform you that you actually have stage 3 oral cancer. There are several treatments that we can get you on right now, and we could talk more about that too. So let's get to it.
Oh, okay, so that's why I've been feeling this big lump on my lips and numbness and bleeding constantly. I thought that was a problem. So what you found on the test, do you mind giving me more information on what you found and type of treatments I should go through?
Yeah, sure. Well, as far as your biopsies go, we took a look at the leukoplakia and the lesions, and it shows that the cells themselves are in the stages of neoplasticity, and what that means is the cells themselves are pushing the other cells around them, interfering with function, and that kind of goes into problems with your soreness, and also with the slight bleeding that you have, and with your smoking and drinking, that really doesn't help as well. All right, well, as far as treatments go, I would like to put you on chemo drugs and also radiation therapy, and also there's antibody that has proven to work pretty well. It's called cetuximab, and basically that blocks the EGFR, which is an epidermal growth factor receptor, and basically it prevents the cells from growing, and that would help you in your case with the cancer itself. And that drug would be delivered through your IV, so you would come in about once a week, and we can do that for you. And then the chemo drugs, well, basically they're going to kill cells, any cells that are in the process of cell division, and that's going to have some risk, basically because it's killing possibly normal cells as well. You're going to run risk of low white blood cells. Your body's not going to be able to fight infections, and then other blood clotting factors like platelets, nerve damage, and also lower sex drive might be a problem too. And radiation therapy comes in. Basically, that is going to destroy the DNA or make it to a point where you cannot repair the DNA, and that would induce the cells to die. So basically, that's what I have for now lined up for you, if you would like to take that. And there's also options about other drugs too. On the newer end, they're still in trial, but I can look more into that if that's something you're interested in. Okay, so basically, I'm just going to have Graham and Cassandra, our molecular scientists, come in right now, and they're going to give you more information on the treatment plans. And yeah, is that okay?
Okay.
My name's Graham, this is Cassandra, and we are molecular oncologists. Your doctor mentioned you would like more information with regards to your tumor and possible treatment options, so I'll just jump right in. What we did was we isolated DNA from your tumor, and we analyzed it using synthetic oligonucleotides engineered to be complementary to common mutations in cancer. The data showed a mutation in the HRAS oncogene at codon 12, where the wild type sequence GGC was switched to GTC, and the mutant protein had an amino acid switch from glycine to valine, which turned the protein constantly on, or it was constantly active, and this likely contributed to the development of your tumor. as this mutation has been shown to be common in many types of tobacco-associated oral carcinomas. There's a new drug called lonafarnib, and lonafarnib is a farnesyl transferase inhibitor, and what that does is it prevents the post-transcriptional fitting of a 15-carbon isoprenoid chain to the HRAS protein, and if you inhibit this step, RAS is delocalized from the plasma membrane where it normally goes about signaling growth and anti-apoptosis factors via signal transduction. So if you can take RAS away from where it needs to start its signal, you effectively stopped RAS transformation of healthy cells into cancerous cells. Now, this would be considerably more risky as lonafarnib is still in clinical trials, so not all of the side effects are yet known. As opposed to some traditional radiation or chemotherapies, photodynamic therapy is localized to the site of the tumor. Treatment would begin with oral administration of the drug mesotetrahydroxyphenylchlorine, or MTHPC. It's a hard one. And while your whole body would be exposed to the drug, only the tumor is exposed to therapeutic light. Now, on exposure to therapeutic light, or light of a certain wavelength, the drug produces active oxygen species. So by selectively treating the tumor with light of a certain wavelength, we can protect healthy tissue without compromising the control for the tumor.
All right, thanks, Graham. He is a very knowledgeable molecular oncologist, so you listen to him, all right? All right, when looking at a scale of where your cancer could be, you're pre-metastatic, so that means you are in the dysplastic stage. And this is good because, I mean, it's not good, but it hasn't started spreading to other organs or gone past the basement membrane, so we can hopefully control it before this happens. Since you are in the pre-metastatic phase, I wanted to take a tissue sample, which we did, and I isolated it in an in vitro sample. And we found that you have a few enzymes that are repressed and a transcription factor that is actually constitutively on. And I will show you this. It's in the arachidonic acid pathway, is what we found. Alright, so the enzyme that you're lacking is right here on this diagram. This is the arachidonic acid pathway. It's called lipocalin type prostaglandin D2 synthase, which it's currently being repressed. Not sure why, but we're trying to figure this out. But as you can see above it, anything in red is being increased, and anything in green, we're seeing a repression or a decrease in. So above it is COX-2, which is involved with cell proliferation, angiogenesis, and anti-apoptosis. Earlier, Graham mentioned the RAS pathway, which he found a mutation causing the glycine go to valine, which causes it to be constitutively on, but that's a little besides the point anyways. RAS here is converging with COX-2 on the arachidonic acid pathway, which is bad because you're seeing a large increase of COX-2 and not enough lipocalin type prostaglandin D2 synthase to cause a negative feedback loop to turn it off. So with the lack of this enzyme producing prostaglandin type 2, we're not seeing the negative feedback, and also you are just lacking that metabolite in general. So to fix this, we would like to substitute prostaglandin type 2. We'll give you that orally. So lonafarnib, the drug that Graham wants to implement, which I would like to implement as well, attacks the RAS mutation, which is good because we see this convergence point between the RAS pathway and the arachidonic pathway. So that should hopefully lower your levels of COX-2. And also, the substitution of prostaglandins will also cause the negative feedback loop, allowing us to get a handle on all the cell proliferation going on. Overall, these treatment plans that we have designed for you, they're specifically for your cancer, so hopefully we'll be able to get a handle on things and eliminate it and keep it from metastasizing. So just do what your doctor tells you and hopefully do what we tell you and hope you feel better.
Yeah, Alex, why don't you have a seat? So how things been going after a month of treatment?
Well, since starting the treatment, I've been quit smoking and drinking to help my recovery. But ever since the treatments, I've been pretty tired, lack of eating. It really hurts to swallow from all this radiation therapy and chemotherapy. But I have been going to the dentist, like you said, to make sure no infections start to build up in my mouth.
Good. Hey Alex, well, I'm sorry that you've been having all these symptoms, but it's really good to hear that you go into the dentist to make sure there's no infections. As far as the treatment's going, everything's looking pretty good, and you're saying that you had some soreness and some symptoms. What I can suggest is a little bit out of ordinary, unorthodox per se. It's more like a trial treatment kind of thing, and it's called hyperfascinated radiation therapy, and that should alleviate the symptoms, because what's going to happen is we're going to take the dosage of the radiation and we're going to cut it up into smaller fragments, but you're going to have to come in and do it more often. So we're going to drop the dosage, but we're going to increase the frequency of the therapy. But that should, in theory, help with the symptoms.
Oh, that sounds great. When can we get started? My doctor has told me that I'm likely to recover with a 65-70% survival rate, because he sees no evidence that the cancer has spread to the cervical lymph nodes, which is good. But since I've had cancer in the head and neck region, we're gonna make sure I'm gonna go see him frequently to make sure I have not acquired a second primary tumor of the upper aerodigestive tract. But with me stopping smoking and drinking, I've significantly increased my chance of recovery. So I'll probably be able to live another day. I've been eating healthier, and throughout the months, my doctor has told me I'll probably more likely see him less frequently, which is good. And but so far, all the test results has shown that he has not seen any signs of cancer, which is good.